Hi, everyone. So happy to see a full attendance out there. We have a very exciting meeting planned for you. First off, before we get started to introduce our members, I want to really thank Amy Garcia from the Westchester Restorative Health for our lunch for today, and Serafina Mastro, who also provided the cookies and the little snacks and the water. She unfortunately was not able to be here today. I would like us all to please stand for the salute to the flag, please.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty
And justice for all.
I'd like to take a moment for our first responders. Thank you.
Thank you. We could all be seated. I'd like to just go around the table for everyone to introduce our members of the board here.
I'm Kathleen Macy.
I'm Noreen Parrell, and on the back of the room and on the table, there's flyers for safe driving that's sponsored by AARP. You can do it online or go to the Cedar Manor Nursing Rehab. Check it out, and it'll reduce your rates on the insurance.
Rosemary Panio,
Jenny Minton Grasso,
Maria Fama.
I'm Deborah Marks. I'm the liaison to Assemblyman Slater's office. We would also like to take this opportunity to invite you next Friday, July 24th, 10 a.m. The Centers for Medicare and Medicaid are coming to Jefferson Village Community Center. It is open to the public, and they're going to be talking about waste, fraud, and abuse and scams.
What time?
It's a free program.
10 o'clock.
10 o'clock.
Good afternoon, Joe Falcone, Recreation Commission Liaison.
Diana Quast, Town Clerk, and I'm going to take a moment to wish my youngest grandson happy birthday today.
how young?
He is 8 today.
Oh, God bless him.
What's his name?
Good age, good age.
Thomas. Happy birthday, Thomas.
Okay. I'd like to introduce Kathleen to introduce our next speaker, please.
Good afternoon. It's nice to see everybody. It's a pleasure to introduce our first speaker today, Yorktown's new Chief of Police, Justin Foley. Wait. Okay, come on up. You're going to have to stand with me while I say the rest of this. I am. But hopefully you are familiar with this. He's a lifelong resident of Yorktown and a Yorktown High School grad. He began his law enforcement career with NYPD in 1998. He joined the Yorktown Police Department in 2002 and has served our community in many roles the past 24 years, so not that old. And he was a patrol officer, a canine officer with his partner Moose. You know that's a dog, right? Traffic safety officer, sergeant, lieutenant, operations commander, and now chief of police. Throughout his career, he has earned numerous commendations for meritorious service, exceptional merit, and life-saving efforts. Today, he'll share more with us about his background and discuss the role of the police department in serving and protecting our community. I'd like to say a few words that his last boss said about him. They're very, very respectful. Justin is loyal, trustworthy, respectful, a man of faith, a family man, and hardworking. And he deeply cares about Yorktown. Please join me in welcoming Justin Foley, Chief of Police. Thank you. Don't forget to introduce your guy.
Yep. Thank you for the introduction. It's a pleasure to be here today. Just want to introduce my captain. He's my second in command, Mark Rapisar, so he's here as well. And just like that was touched on before, I'm a lifelong resident. I grew up in Yorktown. I raised my 5 kids in Yorktown. I got a little Foley complex in Yorktown. I bought the house behind my parents' house. My brother, who's in law enforcement, he's in the house now with his kids, and my mother lives there. across the street, my brother and I'm sorry, my sister and my brother-in-law who's retired from the Yorktown Police Department live there too. So we are vested in this town. This is my town. This is your town. This is how we want to keep it. You know, I was part of the youth group, Boy Scouts, Eagle Scouts, Altar Boy. Like, this is my town growing up. I went to New York City. I got a lot of experience there, but I always wanted to come back to my roots here in Yorktown and serve the community. Chief Noble did a fabulous job here. We want to continue the mission of serving the community. Community policing is going to be our #1 priority here. Obviously, protecting life and property, even the low-level qualities of life crime. So if you guys have any problems going on, if there's an emergency, please call 911. If you have a non-emergency, please call 914-962-40141, and we will get an officer over to help you guys out. If you need to call me, you can call my office at any time. I'm available 24/7. If I'm not working, somebody will get a hold of me, and I will get back to you. If you have any questions, I'll be more than happy to answer it. Just in the meantime, if you're not part of the Nixle program, please go on the Facebook post or our department website, and you can get on Nixle. We usually give a lot of weather updates, any emergencies going on, road closures. You get a lot of valuable information through there as well. If you haven't seen the most recent post, the town board supported us for the bike unit. So we have a bicycle unit that you will see deployed, most likely in the town of Yorktown, just to start off before we expand. But we're going to be out there for community policing, engaging with our youth. I know the e-bikes is probably one of the concerns that's going on now, especially them zipping by some people on the sidewalks and stuff like that. So you will see them out there. If you see our officers out there, please engage them. Please say hello to them. That's why we're out there, to engage the community. So if you have any questions, I'd be more than happy to answer them. If not, I know you're here to see the doctor. So he's got some valuable information for you guys as well. If not, it's a pleasure to take over for Chief Noble's position. It's an honor to serve the community and represent the community. And my command staff is going to do everything we can to continue the mission that we've been doing. Appreciate it.
I have one question.
Sure.
The e-bikes, are they considered motor vehicles, so they're not allowed on the bike trails?
They're assisted living, so there's 3 different classes, and I don't want to speak offhand on getting any of the actual laws wrong. What we are trying to do is work with the town board to get town codes to make more enforcement going on. One of the biggest issues we have with the e-bikes is you can only issue, it's illegal to operate the e-bike on the age of 16 years of age. However, you cannot issue a juvenile a ticket for that. What you can do is issue a ticket to the parent, but the parent has to be present watching it. So as we notice, most of these kids are out there, and a lot of it is just the parents not being educated on it. So one of the things with the bike unit being out there is education is going to be our #1 tool right now before we take enforcement action. Obviously, if we have to take enforcement action, we will. But we're working with the town board. We're trying to get some town codes and make more enforcement action available for us too. And obviously, we don't want the kids getting hurt. We don't want people walking on sidewalks getting hurt as well. But they're illegal to be on sidewalks. The Westchester County Bike Trail, I can't give you an answer for that offhand right now. I can get that back to you. And just on a side note, you can correct me if I'm wrong, Noreen, is we should be here probably in the next few months. And I believe we're going to have officers down here addressing identity theft and scams, which is prevalent amongst the elderly community, falling victims for that. So we will be down here probably in the next few months, I believe, addressing that as well.
Yep,
So.
thanks.
I have a question.
Sure.
Are helmets included in the rules and regulations for
Speak into the mic, Kathleen.
Are helmets included in the rules and regulations for e-bikes?
They are at a certain age, on the juvenile age group, but what we're going to try to do with the town code law is impose it on everybody that's going to operate an e-bike in the town of Yorktown.
Are there any more questions from the audience? Wow, see, we have a great town. We have a beautiful town.
Thank you for having us. Look forward to interacting with everybody.
Don't forget your lunch.
Thank you. Please enjoy a sandwich and some lunch that we saved there for you. There are sandwiches and some dessert there for you.
It's in the bag.
It's all bagged.
Thank you so much. Thank you.
Thank you. It is, really. So, Diana?
Are you going to do, are you doing
Do we
Ed or?
want Diana?
Let's do Ed. Do you want to do Ed now, or do you want to do
Ed.
the doctor?
Oh, okay, I gotcha. Our next person on our agenda is also very important. That's Ed Latchman, and Ed is our town supervisor, in case you didn't know.
Hey, hope everyone's doing good today, keeping cool. You know, I just want to talk briefly. Everyone knows we have the air quality alerts out there, so please try to limit your time outside. I've been monitoring. I haven't checked in the last couple of hours because I was tied up at Northern Westchester Joint Waterworks. But, you know, once the rains come, it'll clear up quite a bit, from what I'm told. So we'll keep looking into that, and I'll keep doing updates as needed. Hopefully we get the pool open this weekend, but from what I hear, Saturday into Sunday, there's going to be some heavy rain, thunderstorms, and flooding. So we may be in that window. So it might put a damper on Sunday's pool hours. You know, I just want to talk a little bit. I'm glad that Chief Foley was here, Captain Rapisarda. You know, we do have a great police department. The new bike unit coming out, that idea, actually, I'd love to take all the credit for it, but I can't. It came from our patrol officers who said this would be a great way for us to get out there. And, you know, we talk about it. You don't want to lose a guy like Bob Noble, but when you do, you want to find a guy like Justin Foley who could come in here, because they come from that culture of excellence that our police department has really, really had. And, you know, we made a change, I guess it's, 2 years now when we put the captain position in? You know, I lobbied the board and got support for reintroducing a captain's position. We used to have it in the town, and it disappeared a long time ago. And that was knowing that eventually Bob was going to retire. And instead of there being, you know, 3 people that you're trying to train, you're able to take the person that you think is the best at that point, put them into the captain's position, and do some more one-on-one training. So I was very happy to see Captain Rapisarda here today, because this is the stuff that our next chiefs will all need to know. So but once again, that culture of excellence. Work as a team. Everyone has that same feeling, and it's been a philosophy of our police department and our town board for a while, of trying to look for people that are tied to our community, whether they were born here, went to school here, moved here within the area, or you get your lifers like Chief Foley. That's what you want, because it's all about Yorktown for them. It really makes a difference, and I am just, you know, very thrilled that our police department has moved along on this. That's really, you know, I just wanted to come in and say to everyone, just enjoy the rest of the summer here as we go. We have a meeting next month also?
Yes, we are.
So our break will be in the winter time, right? Correct, for
January and February.
So we'll be here next August. Hopefully I'll be able to make it in. If not, I'll ask Sergio to come in. He's always entertaining. You know, we have some great things going on in town. I know the new Wonder just opened. I think in September we'll be looking at Bobo's Cafe opening. So there've been a bunch of great things going on, and just keep your eye out. We'll be looking to do some more. Actually, our town clerk has been working on some kiosks to try to give more information, not only inside a couple of our buildings, but even having one outside, possibly by a heavy intersection of bikes, walkers, and townspeople, which is over by the railroad station, Railroad Park. So we're really looking to add some things that help quality of life, whether it's finding things, whether it's our bike patrols, going out and educating our kids so we can not have them riding on the sidewalks with e-bikes, knocking people over. So a lot going on, and we're always open to suggestions. Please, anytime you have a question, my number is easy to find. My personal cell number is out there, as well as my town cell phone. And you could always stop by my office, give me a call up there, speak with Cindy Smith, my administrative assistant, and we could get taken care of what you need taken care of. Thank you, and enjoy the summer.
Thank you.
Ed, thank you so much. Thank you. Now, Diana, would you,
Are we ready?
I'm ready.
okay. Our prestigious town clerk is going to make a presentation on healthy aging and preventive, no,
No,
that's the
you're-
wrong,
Yes.
I don't have it.
Doctor.
Diane, I don't have it.
Wendy will introduce him.
You're supposed to introduce Wendy.
Wendy can introduce
I'm sorry, I'm trying to get you. Okay, yes, I know Wendy McNamara. Wendy McNamara is the Coordinator of Communication Affairs for the New York Presbyterian Medical Group, which is right down the road. We call it the Hudson Valley Hospital, and it's famous because it's been here forever. So would you please welcome Wendy? Thank you.
And we also really want you to know that without Diana, we wouldn't have Wendy introducing her person. So Diana's a big help to us to get it on the TV screens for us. So enjoy the
Thank you,
speaker.
Kathleen and Jenny. Good afternoon, everyone. And by the way, thank you, Diana, for your technical assistance today. My name is Wendy McNamara. I'm the Community Affairs Coordinator at New York Presbyterian Hudson Valley Hospital. And once again, I'd like to extend my sincere thanks to Jenny, Noreen, and the board for inviting us to join and speak today. New York Presbyterian Hudson Valley Hospital is proud to be your neighborhood hospital serving the heart of the Hudson Valley community. We offer a broad range of specialized services including cardiology, cancer care, digestive health, orthopedics, obstetrics and gynecology, gastroenterology, and pulmonology, all close to home. It is now my pleasure to introduce our guest speaker, Dr. Anthony Tramontano, a member of our growing cardiology team. Dr. Tramontano was a board-certified cardiologist with more than 20 years of experience in clinical care, academic medicine, and cardiovascular research. Known for his patient-centered approach, he develops personalized treatment plans by taking the time to understand each patient's unique medical history, lifestyle, and goals. During his career, Dr. Tramontano has served underserved communities in the Adirondack and Champlain regions, championed cardiovascular health education, mentored future healthcare professionals, and held numerous leadership roles, including chairman of medicine at Adirondack Medical Center and several medical directorships. Dr. Tramontano joined New York Presbyterian Hudson Valley Hospital earlier this year, and we are delighted to welcome him to our team. We're fortunate to have his expertise and wonderful manner, engaging manner, serving our community. Please join me in welcoming Dr. Anthony Tramontano.
Just as a reminder, before he starts, when he asks if there are any questions, we have to make sure we repeat them on the microphone so our audience at home can hear them.
Absolutely.
Okay. Thank you.
Next slide, please. Wendy, thank you. Wendy, thanks so much for the introduction. It's great to be here and to speak with you and spend this time with you today. Originally from Long Island, I did spend some time up in the Adirondacks, as was mentioned, so I do feel like I'm kind of back home in the tri-state area. So thanks so much for that very warm welcome. We're going to talk a little bit about healthy aging and preventative care, obviously focusing in on the cardiovascular system. Before I start, I always like to know, what's the audience like? So I'd like to ask some questions. So this is going to be really interactive. Just put your hand up at any time so that we can kind of make this kind of fun and educational for you. So my first question before we start is, can atherosclerosis, plaque in our arteries, be prevented? No, yes, only if with a family history, or only with medications. Does anyone have any?
B.
Huh?
I don't understand.
I say
I don't
B.
understand the question.
It's up on the screen.
You think it can be?
I think it can be.
If you think it can be, put your hand up. If you think atherosclerotic disease is genetics, is nothing you can do, put your hand up.
It's that too. It is, no.
There's some conflict
Some
there.
people have the genetic aspect.
True.
And some people have prevented it.
Understood.
Fighting the genetics of it.
A good point. No, thank you.
I'm sorry.
Next slide, please. Can doctors estimate your risk of a heart attack or stroke from atherosclerosis before symptoms occur?
I think so.
Do you think yes or no?
Yes.
Yes for hands up?
Yes.
No? All right, very good. A very smart audience here. This is very good. Next slide, please. Thank you. If 8 out of 10 premature heart attacks and strokes are preventable, which risk factor do you think has the greatest impact on reducing cardiovascular risk? Smoking, high blood pressure, cholesterol, diabetes, unhealthy diet, or lack of exercise?
All of them. All of them.
Wow, okay. You don't need me here. You don't need me. Yeah, you guys are great.
You're talking to an older group.
You guys are great. Next slide, please. Which diet has the strongest evidence for reducing cardiovascular risk and promoting longevity? Low-fat diet, a high-protein diet, the Mediterranean diet, or a diet based on many supplements and vitamins? C, the Mediterranean diet. Okay. You guys, I think you guys got 100%. Very good. Next slide, please. Thank you. So this is a kind of a little bit of a disturbing slide. We see two knees here, right? And the knee on our left, but the person's right knee is very inflamed, right? It's red, it's swollen, it's warm, it's probably painful, right? And that process is called inflammation, right? And inflammation is kind of the building blocks, the underlying problem of atherosclerotic cardiovascular disease. Inflammation at its most simplest is repair, right? You know, you cut yourself, you get an injury, the body tries to repair it with those things that you see. But if you have chronic inflammation over long periods of time, it can do damage. If you have arthritis, that's chronic inflammation. If you have rheumatoid arthritis, that's chronic inflammation. If you have coronary artery disease, that's chronic inflammation. So inflammation is kind of the thing that we want to look at and target in many of our treatments. So as we go forward through this presentation, I just want you to think about that. Next slide, please. So what is inflammation within the vessel wall? The fancy word is atherogenesis. If you look at the first part of the slide there, you have a vessel. It has a wall. There are multiple layers to that wall. What starts the inflammation is cholesterol, right? So if you think about atherogenesis, you have kind of two things like a fire, right? You have wood, and then you have the actual flame that burns the fire. The wood is the cholesterol that gets deposited in the vessel wall, and the inflammation is the fire, right, that keeps that fire going, that burns and creates that plaque. So what happens is that the first insult, if you will, is that cholesterol filling up or building up behind the vessel wall. The body then tries to repair itself to remove that cholesterol. That's the inflammation. Now that's happening during a short period of time. It's not a big deal. But if it's happening over many decades, what happens is right there, that second part of the slide, you see a large plaque that is blocking that artery, right? So it's not just the cholesterol, but it's the inflammatory cells in the vessel wall itself that creates atherosclerosis. Atherosclerosis probably begins in the first decades of life. I mean, the American diet keeps people like me in business, right? But it's the American diet, unfortunately, that over many, many years leads to arteriosclerosis. Next slide, please. So how do we talked about some of these questions. How can we calculate or get an idea about what someone's risk is? There's a thing called the Framingham trial, which was done many, many years ago in Framingham, Massachusetts, which looked at developing a risk score. So what is your risk for atherosclerotic heart disease? This is a screenshot from the American Heart Association. The most novel or new iteration of the risk score is called the Prevent Online Calculator. If you look closely, it has sex, age, blood pressure, your HDL, your LDL, your total cholesterol, your BMI, and there's also some other data on the bottom where you can put protein and whether you have diabetes or not. Feel free to go to this. It's free. You can put in your numbers and you can calculate your risk. Intermediate risk is kind of what we deal with. That's kind of our bread and butter job in seeing patients, right? Someone that's very low risk doesn't need to see a cardiologist. Someone that's really high risk will need something done. But, in the day-to-day work that we do in the clinic, we want to look at that intermediate risk patient. Do you have risk? What can we do to find out about it, and what we can do to address it, right? What can we do with that information with risk? Intermediate risk is considered if you're between 7 and 20%, which means if take like 100 people like you, if we say 7 to 20 of you are going to have a heart attack in the next 10 years, that would be considered intermediate risk. And that's the patient population that you really want to see and where we can really have a lot of work to do to prevent heart attacks and strokes. Right? Next slide, please. So we talked about a risk calculator. There's something that we actually can do to look at the atherosclerotic burden in you, in the patient, right? And that's looking at calcium. So if you look at the top, you have a little diagram, a little cartoon that looks at the progression of atherosclerotic heart disease. As atherosclerosis progresses over years and decades, the core becomes bigger, and the cap over that core becomes aged, becomes older, and what happens is it becomes calcified. And that calcium is very easy to see on a CAT scan. When you do a CAT scan of someone, anything that has calcium, like bone, is white, right? So when you look at the heart, you're looking at the blood vessels, what you're actually seeing is white spots within the coronary circulation. So it's not looking at risk, it's actually looking at disease burden, right? So the coronary calcium score is something that we like to do for these intermediate patients that I just mentioned, to say, do you have the disease, and how much disease do you have, and what can we do about it? Next slide, please. So here is actual scans of the heart. So this is a computer tomographic image or a CAT scan of the heart. So if you're thinking about what you're looking at, it's slices right through your chest, and it's the left side of the screen is your left shoulder, and the right side of the screen is your right shoulder. I don't have a pointer, and I'm sorry about that. But what you're looking at is a cross section of the heart. The two slides on the left, the slide up on kind of 9 to 12 p.m. On the upper left corner is normal, right? So you don't see anything white. And as you go around, right, the next slide right there, you can see a little blip of calcium. That's in the LAD, or the artery going down the bottom. Then the next slide is a lot more calcium in the LAD. And then if you look at the very last slide on the lower right-hand corner, there is tons of calcium in the left anterior descending, the right coronary artery, even in the aorta, which is that kind of round circle. Do you see on the bottom there? Can you put right there? That's the descending thoracic aorta. It looks like it's entirely calcified. So this person has a very high calcium burden. The calcium score is 1,200. That patient is at high risk for having heart attacks and strokes and basically the disease of ischemic heart disease. I know I said a lot there. Does anyone have questions about calcium scores? Please, sir. Yes.
At what point can you determine, or do you do scans to determine what someone's score might be? And how do you know you have symptoms or something that might say, hey, we need to test for this?
And that's a great question. I think
Could you repeat the question?
Yeah,
please?
absolutely. So that was a great question. When should we do the test, and is it based on symptoms? I think that's what I'm hearing. So first of all, if someone's having symptoms that are concerning for ischemic heart disease, like angina, or we think they're having a heart attack, they need to go to the emergency room, right? They need prompt care. If someone is having symptoms once in a while, like they're having some shortness of breath, or they're noticing some chest discomfort with exertion, then we might do a stress test, maybe with this as well. But this is kind of a static picture. Right? When someone's having symptoms, a lot of times you want to do a provocative task that exercises and gets them on the treadmill. Do they have symptoms? What's their blood pressure? What's the ECG with some imaging involved? So, we want to kind of reproduce those symptoms. That gives us a lot more information. This is a little bit more prognostic in the sense of you're coming and seeing me, you have a family history of heart disease, you're 65, 70 years old, you have a little bit of blood pressure, pre-diabetes, your cholesterol's up, you're intermediate risk. Do you have coronary artery disease? This would be the test that I would like to do, because it could help us to maybe focus on the intensity of treatment I would want to give you. But symptoms need to be addressed. I think if you're having really bad symptoms, you need to go to the ER, and if you're having a heart attack, you need to get a catheterization, right? But if you're having ongoing symptoms that are getting worse, that's something that would certainly provoke us to get you on some medicines, get some stress testing, and take care of you very, very closely.
Can you have no symptoms and feel in good health and all that, and still have a serious problem?
Yes, absolutely. So, people can have a lot of coronary disease and not know it. Fortunately, there's sometimes patients are very sedentary, right? So they don't exercise a lot. So they say, well, I feel fine. I don't have any symptoms. But what are you doing every day, right? Sometimes you get them on the treadmill, 2 or 3 minutes, they're having tons of chest pain, or they're very, very short of breath. So again, it's like those types of patients where you have to dissect or kind of see what's going on. This test can be very helpful. Thank you. Next slide, please. So here are the calcium scores, and you have Zero, if you have a zero calcium score, you are at very low risk, right? So if someone is intermediate risk and they have a zero score, this is the patient where you're going to really talk about getting healthier. What's your diet? Can you lose weight? Let's take a look at your cholesterol. We're going to see you back in 4 months and see how you're doing with all of those kind of plans. If your calcium score is greater than 100, then we want to think about starting some medicine. So if your calcium score is greater than 100, I might want to start a low-dose aspirin, and I certainly would want to get you on a cholesterol pill. I talked about that first slide as kind of cholesterol as the beginning of inflammation. There's all different types of cholesterol. LDL is the bad cholesterol, and it's bad because it's just the right size that it gets stuck in the vessel wall and starts that inflammatory process. So the LDL is kind of kind of the target that we look at when we're starting cholesterol-lowering therapy and trying to get it below a certain number. If you have a calcium score greater than 300 to 400, you're certainly high risk, and we kind of consider you as someone who's already having established ischemic heart disease. I would like to see your bad cholesterol below 70. That would be kind of a target. So, age tells us how old you are, but the calcium tells how old your arteries are, right? How much inflammation is there. There's a lot of talk about biological age. That is a very real concept because, I've seen, unfortunately, people that really don't take care of themselves, like heavy smokers, people who have diabetes, morbid obesity. I mean, their vascular system is very old, right? I've seen 28-year-olds have MIs and heart attacks, especially up in the Adirondacks, just very unhealthy lifestyles, unfortunately. So that biological age is something we should always think about. Next slide, please.
Question?
Question, yes.
Are there any side effects from the cholesterol medication?
This is something I talk about every day. Are there any side effects of cholesterol medication? There are multiple cholesterol medications. I think you're probably referring to statins, which are probably the oldest, been around for a long time and are very commonly used. All medications have side effects. I think everything in life has a side effect. We always give someone a medication or a therapy because we think the benefits outweigh the risks. I will say that statins are very well tolerated. Myalgias, muscle cramps, muscle pain is probably the most common side effect, but not common. Like anything, you want to start medications low and go slow. And you want to follow up the patient, right? How you doing? How's the med going? And you stop the pill if the patient has a side effect. But yeah, very good question. There's a lot of buzz out there about statins. Everyone always has something to say about a statin. I don't want to take it. My brother has a lot of cramps. My wife didn't do well with it. I think there's just kind of a lot of, in the community talk about statins. But they are very good pills. And I think if you need to be on one, you should be on one. If you don't do well with statins, there are other meds to go to if you need to. Yeah, so good question. Thank you. We talked about doing the online calculator. We talked about the calcium score. There are biomarkers that we use as well to calculate your risk. Lipoprotein little a. This is something you might have heard about in the news. It's very common. It's recommended that everyone get tested once in their lifetime. When we look at cholesterol and LDL in particular, lipoprotein little a is part of that calculation. Lipoprotein little a is genetically determined, and if it's high, you usually have a much higher risk of atherosclerotic disease. Lipoprotein little a is considered to be very atherogenic. It's kind of this, if you look at it microscopically or molecularly, it's a big blob of cholesterol, but it has this kind of protein tail on it, which seems to really stimulate inflammation. So when we look at LDL, the lipoprotein is part of it, but we don't really know how much lipoprotein A is there. So it's always recommended to check this, especially when someone that, again, is intermediate risk, has concerning symptoms or family history. You want to get that lipoprotein little a. There are some meds that can reduce it a bit, but there are some newer trials going on right now that are looking at actually trying to reduce this cholesterol. They're looking at some oligonucleotides that actually go into the nucleus of the cell to actually influence the transcription, the genetic precursors of this actual protein. So a lot of exciting things happening in cardiology with lipoprotein little a. Apolipoprotein B is another marker that you may have come across. Again, it's at the protein component of cholesterol. Sometimes when we measure cholesterol, people's triglycerides, individuals' triglycerides are very high, and we cannot calculate your LDL. So we'll look at the apoprotein B. It helps us to get the number of particles, not the total amount of cholesterol circulating, but the number of cholesterol particles, which is associated with risk. Okay, so another marker that we can use to kind of, again, help dissect what's going on with a particular patient. High sensitivity CRP, I don't use very much. It's very non-specific. Anything, I mean, if you have a cold, your CRP will be up. If you have arthritis, your CRP will be up. But it can be a good marker in some patients to see what their inflammatory levels are, right? Do they have this chronic inflammation going on? That could be a good marker. Troponin and BNP are something that I never do in the office, but we do all the time in the emergency room. If someone comes in with chest pain, we look for a troponin, right? That is a marker of acute myocardial injury, right? Cells are dying in your heart and releasing the intracellular components into the bloodstream. That's a sign of ongoing injury. So someone has chest pain, they're having a heart attack, we monitor those troponins going up. That's a very important biomarker in the acute care setting. Pro-BNP is a marker of stretch of the myocytes, so the cells in the heart, and is kind of a surrogate for heart failure. So it's something that we might want to look at time. Next slide, please. Thank you. So, we're really moving into personalized care, right? I mean, everyone has a unique composition, unique history, unique family history, unique genetics. So, we talked about that risk score, but with the imaging, with the biomarkers, with the calcium score, we really can focus in on what is your particular atherosclerotic burden, right? What is your lipid profile? What is your risk for having a heart attack? And this is what we do day to day in our cardiology office. Any questions on imaging, biomarkers? Okay, next slide, please. Thank you. So we talked a lot about the disease process, how to calculate the risk, how do we prevent it, right? And these are the things that we had in that first slide you all did so well with, right? These are the things that we all have to think about day to day. Eating better, right? So, I mean, it's something that we all need to think about. I tell patients, they say, well, doctor, how do I eat better? I'm like, when you go into the supermarket, just stay on the outside of the supermarket. Don't walk down any of the aisles. That's the first thing you can do, because all the whole fresh food is on the outside, right? The other thing is that there's way too much carbohydrates in the American diet, right? The processed, simple sugars, the bread, the rice, the pasta, the peas, the corn, the processed food. That's what puts the excess fat on. So I say stay away from the white foods, right? It's kind of another go-home thing that I tell you about. But we want to try to eat whole foods, foods that are not processed. We have blunt teeth. We have long sacculated digestive tracts. We sip fluid, right? We don't lap it up with our tongues. We sweat. We don't pant. We are not carnivores. Carnivores have sharp teeth. They rip, they swallow, and they poop. They have very short, the dogs, lions. And usually dogs, lions, tigers, they don't get atherosclerotic disease. They do not get heart attacks or plaque. So we're much more herbivore-ish. I mean, we're probably omnivores, and I enjoy my steak just as much as anyone else. But we really have a very herbivore-like, physiology. So you should really keep that, more plant-based eating. Be more active, right? Be more active. We hear this all the time. Get more sleep. Every patient that I see, I ask, how are you sleeping? And people who are not doing well, they don't sleep. I mean, I would say probably 75% of my patients tell me they do not sleep. They either cannot fall asleep or cannot stay asleep. So sleep quality, to me, is kind of a window onto health, right? It tells you what you're eating. It tells me what you're doing. It tells what's your blood pressure at night. Do you have sleep apnea? So many of these things are related to underlying cardiovascular disease, arrhythmias, sudden cardiac death. People die at nighttime, right? So sleep is something that's very, very important. Tobacco obviously is a big one. You don't want to smoke, right? Smoking takes about 10 years off your life. You want to manage your weight. You want to control your cholesterol. You want to manage those blood sugars. I like to check patients for even pre-diabetes, because even that pre-diabetes and a little bit of insulin resistance is a risk factor. So you can lose a little bit of weight, get the sugars a little bit better, watch the carbs. These are things that could really have an impact over time. And most importantly, not most importantly, but in addition to blood pressure, people do not feel high blood pressure, right? It's called the silent killer. People don't know what their blood pressures are. I think I recommend probably to every one of my patients to get a blood pressure cuff. You don't need to be obsessed with checking your blood pressure, but I think it's a good idea to do. I think if you're on meds, a very good idea. And I think if you're not feeling well, a good idea, right? What's your blood pressure? What's your pulse? When you see your doctor, you should check your blood pressure maybe every day for that first few weeks coming in. That gives us a lot of data, because who wants to be in a bright, white room seeing a cardiologist, right? I mean, everyone's blood pressure is going to go up. What your blood pressure is at home can kind of give us what's your blood pressure in your kind of your normal habitat can give us information so we don't ever over medicate you, right? So I think that's important. Next slide, please. So I wanted to add, we talked about healthy aging. Where do people in the world have the most success at aging? It's called the blue zones, right? So I'm Italian, so I had to show some pictures of Italy, obviously. This is Sardinia, right? I mean, it's a beautiful island. I've been to it twice, off the coast of the western coast of Italy. We have a lot of 100-year-old plus people that live in Sardinia. Also places in Japan, Costa Rica, Loma Linda, California. These are the blue zones where there's a lot of 100-year-old plus people. What is the common denominator of these communities?
Red wine.
Huh?
Red wine.
Red wine's a big one. Red wine's a big, maybe not in Japan, but I agree. No, I think good red wine, olive oil, whole food eating, active lifestyle. People, not people that go to the gym, but people are just active all the time, right? And it's a place where family is more important than work. I mean, I am an overworked cardiologist that works a lot, but I can tell you, the American lifestyle it's work. I mean, we know we prioritize work, but family is certainly more important in these communities. And older family members are revered, and they're part of the family, and they're not isolated. There's so much isolation in the modern lifestyle, right? I mean, at all age levels. There's meaning, faith, community is very important. They cook their own meals, right? So, healthy eating is not just, well, doctor, I ate a salad every day. It's what you're eating, it's when you're eating, it's who you're eating it with, right? I think that's very, very important, right? There's a big difference between having 2 glasses of wine over 2 hours every day or, drinking at a bar, right? I mean, that's a different way of consuming alcohol. So yeah, Sardinia, beautiful place. Next, I think the final slide. So because I'm Italian and we're on the kind of the Italian kick, I just wanted to leave with Cicero. Marcus Tullius Cicero was a great Roman statesman back in the day. He lost his head to Mark Antony, but he was a great man during the Roman Republic. And he said, moderation is the companion to wisdom. I just wanted to use this phrase as, we talked about a lot of things here. We don't treat you like a ticket, and we don't treat numbers, we don't treat images, we treat the patient. And patients come to us in all different stages of life. Young, old, they have problems, they're not doing well, they have a lot of problems, they don't have a lot of problems. We want to try to meet the patient where they are, right? And address one problem at a time. I think people can be overwhelmed sometimes by medical issues, the amount of meds that are going on, stresses of life. The most important thing about seeing a doctor is the relationship with the doctor, right? You want to have a good relationship. You want to trust the doctor. You want to enjoy your doctor visit. Once you trust me, then we can start talking about changing your meds, right? You want to stay in touch with me and let me know how you're doing with your pills or how you're doing with your statin, checking your blood pressures. That relationship is very important. I think it's a scary time in the world, especially in medicine, with these things. I mean, AI, it's all over the place. I mean, I use AI. I think it's going to be part of the world, but it's never going to replace the interpersonal humanism that's needed or the relationship that's needed in medicine. I hope not, anyway. Next slide. Thank you. Are there any questions? Thank you for your attention. I appreciate it. Yeah. Yeah, is taking statins at night is the best time to take statins at nighttime? That's your question. You're right. The liver does most of the cholesterol synthesis and metabolism and does a lot of that during the nighttime hours. So it is recommended to take statins in the evening or nighttime. Correct.
But the doctor my doctor didn't advise me. They just put on the bottle, take one a day.
Right.
They don't specifically
Right.
say take this
Yeah. So those are two really good, these are really good, two good points that you bring up. Number one, I always tell patients to take statins at night. Sometimes patients have problems taking pills. So if you're going to forget it at night, I'd rather you take it every day, whenever, as long as you're taking it. So sometimes it has to be, you have to mitigate the time thing. Yeah. I will say, though, that taking medications and spreading them out is very important. So many patients just pop all their pills at the same time. That is when you have side effects. Like, because you have all these pills kicking in at the same time, multiple blood pressure pills, whatever they are, right? That's when you have side effects. It's always good to spread out pills. Maybe a little bit more inconvenient, but I think spreading out your medications is always a good idea. What about magnesium? That's a very good question. So I just came from the North Country. I lived in the Adirondacks for many years. Everyone is on stomach meds, antacid pills. I mean, everybody. And everyone has low magnesiums. I had a lady that was hallucinating because her magnesium was so low. Magnesium, potassium, sodium, phosphorus as well, are cations. They're minerals that have a charge. They're positive or they're negative. And they are needed for probably millions of reactions in our body, for our nerves to work and for our muscles to work and for our heart to work well, right? Potassium and magnesium are extremely important. So I look at that in all my patients to make sure that their magnesium and potassium levels are normal. Well, it depends on why you're taking it. I think magnesium can be helpful for sleep. So I think a lot of times when, again, people are not sleeping well, like a lot of times my thing is good sleep hygiene, right? So turn off the screens, get more exercise, don't eat late at night, avoid excessive alcohol, always have high-quality conversations with your wife at night. That helps me. No. Long conversation. No, and yes, also magnesium at nighttime can help. I think that can be very helpful for sleep. The preparation is important because some magnesiums that are not well absorbed will have more GI side effects. When you think about cathartic pills like magnesium citrate for like constipation, so you want to be careful which one you use. I think magnesium glycinate or a slow release magnesium are usually the ones that I recommend for like muscle and heart.
What about tart cherry juice to drink at night?
I'm not aware of any evidence that does anything. I'm not aware of any evidence, yeah. You're welcome.
Doctor,
Yes.
We're hearing a lot about cortisol, from the body
Yes.
creates cortisol.
Right. It's a stress hormone.
It's a stress hormone, and it affects the heart then.
Stress affects everything, including the heart, absolutely. But it kind of goes back to what I mentioned about sleep. If you're not sleeping well, your body is on a roller coaster ride. If you stop breathing at nighttime, your heart doesn't understand why all of a sudden you've stopped breathing. You're going to have elevated cortisol. You're going to have elevated blood pressure. You're going to have elevated adrenaline and stress hormones that are released, right? So those are things that you want to try to prevent by making sure you're sleeping well, right? So, sleep is really a window onto health. I think, again, I know I'm repeating myself, but something I talk to about with all my patients.
Do you think it's advisable to take something so you get a good night's sleep? Or do
I
you
think
advise-
first steps is good sleep hygiene. I think adding some magnesium is a good next step. Sometimes I say, if you got some arthritis, you don't feel, I think just plain old Tylenol, I think is a good option. I don't like Tylenol PM because the PM meds usually have something that's like called diphenhydramine, like Benadryl. That is not a good pill to take long term. It's also not a good pill for older people because it is associated with some cognitive decline. So I try to avoid the Tylenol PMs routinely, right? Melatonin, I think, can help you fall asleep, but it might not necessarily help you stay asleep. One of the things that people underestimate is the pillow and the bed. You really want a very firm, hard surface because it is normal to move about when you're sleeping, but you're only going to move if there's pressure points. If you're sunk into this like pillow mattress, you can't move. And that's why people have all this back pain and neck pain and stuff because they're like in this, like marshmallow thing. I mean, it's like, really, it's very, talk about blue zones. I mean, how do Japanese sleep traditionally on tatami mats? It's a straw rice mat with a very, very thin cushion. I've slept on them myself sometimes. I had some sciatica, and I have a tatami mat that I sometimes sleep. I mean, I sleep like a baby. Just saying. Yes, sir, yes.
You were talking about the calcium buildup earlier. So when you find calcium, I understand there's absolutely nothing today that you can do to really remove it other than go in and surgically remove it. Are they working on a
Right.
medication? I mean, what's happening?
Yeah, that's a very good question. Calcium is old
Repeat the
news.
question,
Yes, sorry, yeah. The question was, calcium is a sign of atherosclerotic disease in the arterial system. Can you do anything to remove it? Right. Calcium is old news. Calcium is a sign of an aged, old plaque. Right? The plaque has been there a long time, and it's stabilized. Usually when you have a calcified plaque, it's been there for a while. It might be causing some symptoms if it's causing enough blockage, and that might be amendable to some sort of medication or to a stent. But that's not the same lesion that's going to cause a heart attack. So you remember that one slide I showed you how the plaque builds up. Heart attacks oftentimes happen in arteries that don't have calcium, but there's a lot of inflammation. And that's not something that you're going to see on a scan, right? But it's something that you're going to know because the patient might be smoking, the patient might have uncontrolled diabetes, the patient might have really high blood pressure, really high cholesterol. That inflammation is making the lining of the vessel sticky, or making that plaque that's there unstable, where it ruptures, and then there's a clot that's forming. So when you have a lot of plaque that's creating a kind of blockage has been there a long time, you might have some symptoms, but that's not the same thing that causes a heart attack. A heart attack is an acute inflammatory event, like that knee, right? You have arthritis, but then one morning it's all of a sudden swollen. It's the same thing in the artery. All of a sudden you have a bunch of inflammation in an artery and a clot forms. The clot acutely closes off the artery. You're having a heart attack or you're having a stroke, right? So it's oftentimes very interesting that those vessels are not identifiable on testing. It's kind of the holy grail of cardiology. Back in the day, you used to call it the unstable plaque. How can you determine the unstable plaque? If I could do that, I probably wouldn't be here right now. But anyway, I'd be in Sardinia on my yacht, on my island. No, exactly. But that's a very good question. Yeah, that's a very good question. Yes, ma'am.
When my doctor put me on a statin, the same day, he said I should take medication over the counter, Cunol. Now, I never questioned my doctor because
Right.
that's not where I come from. So I took the statin and I take the Cunol.
Which is CoQ10. Coenzyme,
Yes.
right.
Yes, exactly. And every day I do it, okay?
That's a very good question. So should I take CoQ10 with my statin? Right, I
Well,
guess.
excuse me, doctor,
Yeah.
I'm not asking you because I just had
I understand.
and the cardiovascular doctor, he said, your heart is perfect. I had no problems, but that's why now I'm thinking.
Understood. So we talked about statins and muscle pain. The reason why statins cause muscle pain is that they reduce the CoQ10 in the muscle. So that's sometimes why we recommend giving that supplement. There is some evidence, not a lot, but there is some evidence that if you have muscle pain, sometimes taking the CoQ10 can help mitigate those symptoms.
But that's not what he said. I think my blood pressure was high.
It
Okay,
doesn't do
matter.
anything.
That's why he gave me the statin from the beginning.
The statin will lower your cholesterol. It will not have an effect on your blood pressure.
Well, that's when he prescribed also.
Okay, yeah.
Yeah, I'm not going to stop taking it.
No, yeah, the CoQ10 can help mitigate the muscle pain. But again, there's not a lot of science behind it. You got to realize whenever you take supplements, it's completely unregulated. So whatever it says on the label is fine. Who knows what's in the pill? They're not FDA. There's no FDA approval of those meds. So you have to have some caution when you buy supplements.
And so what are you recommending? Not to take them?
If you're doing well, I would not change anything
I
right
have no
now.
intention of
No,
doing
that's
that,
fine.
doctor.
That's fine. Yeah, that's
you.
fine. All right. Please go see your doctor and discuss this.
Yes, yes.
Yeah. That's also a very good pill. So our blood pressures will usually be the highest during the day when we're doing things, right? Up and about, moving around. Individuals with hypertension usually do better on 2 or 3 blood pressure pills at lower doses rather than just one pill at a very high dose. Because again, that's when you're going to get the side effects. Plus, one pill is not going to last 24 hours perfectly, right? It's going to wear off as time goes on. So usually when I manage blood pressure, I usually like to maybe do 2 types of pills, one in the morning and one in the evening, kind of spread it out a little bit. But it kind of goes back to what I'm giving, what other problems the patient has. Do they have diabetes? Do they have heart failure? Do they have coronary disease? Do they have high cholesterol? Do they have anxiety? Do they not sleep well? That helps me to kind of pick what pill might be good for them. But if you're taking multiple pills, I think it's a good idea to spread them out. Certainly some blood pressure pills can be sedating. Some pills can cause, I'm thinking about like calcium channel blockers can cause edema. And sometimes that's mitigated if you take the calcium channel blocker in the evening. But mostly calcium, you want to take blood pressure pills usually in the morning, right? I mean, yes.
Well, I really want to thank you.
Thank you very much.
We had a lot of questions.
Thank you. They were all very good, yes.
Yeah.
Thank you very much. Thank you.
You could put them on the table. That would be appreciated. Thank you so much. Thank you.
Okay, I just want to remind you that our next meeting is going to be August 21st, the same time here. And I'm really not repeating myself because I forget, but I repeat this after every meeting. I really, really would like to remind our people, if your phone rings and you don't know the telephone number, you don't know who's calling, please don't answer it. If it's someone you know, they will leave you a message. There's a lot of fraud going on. There's a lot of things happening. Once you pick up that phone and say hello, they have your information. A lot of stuff is going on your emails and your telephones. So please, if you don't recognize the number, don't answer the phone. Don't answer the phone. People will leave you a message, and then you could always call them back. Every day, every week, I hear of somebody that's been caught with something. So I don't want anybody to get caught that way. When you're on your computer with your emails, if you don't recognize the email, if you don't, just delete it. Too much stuff is happening to the elderly. I hate to say that, but we keep repeating it, and somebody always gets caught. So be very, very careful. Be cautious of your telephone calls. Be cautious of your emails that you get. As a reminder, we want to remind you about your safe driving course that you can take and save about 10%, 15% on your insurance. It's well worth it. We have our calendars out there for the rest of at the Cultural Center, your lunches and so forth. Please remember to take whatever we have on the counter, and we look forward to seeing you next month. Thank you, and have a...
Repeat the date.